Traumatic, or angle recession, glaucoma. Angle recession is a common finding after blunt trauma and involves a tear between the longitudinal and circular muscle fibers of the ciliary body. Although angle recession is not necessarily associated with immediate IOP elevation and glaucoma, it is a sign of probable damage to the trabecular meshwork. Traumatic glaucoma is chronic and usually unilateral and may occur immediately after the ocular trauma or months to years later. It resembles POAG in pre-Saint-Tartian and clinical course but can be distinguished by its classic gonioscopic findings, Figs 8 to 17, 8 to 18. Widening of the ciliary body band, absent or torn iris processes. Figure 8 to 18 typical gonioscopic appearance of angle recession. Torn iris processes, arrows, a whitened and increasingly vis-ible scleral spur, and a localized depression in the trabecular meshwork are shown. Figure 8 to 17 goniophotograph of angle recession. Angle recession occurs when the ciliary body is torn, usually between the longitudinal and circular fibers of the ciliary body, resulting in a deepened angle recess, arrows. The dark circular deposits located on the peripheral iris represent old heme. White, glistening scleral spur, irregular and dark pigmentation in the angle. Pass at the border of the recession. Traumatic glaucoma should be considered in a patient with unilateral IOP elevation. The patient's history may reveal the contributing incident, although it may have occurred in the distant past and hence forgotten. Examination may reveal findings consistent with previous trauma, such as corneal scars, iris injury, abnormalities in the angle, focal anterior subcapsular cataracts, and phacodonesis. Comparing gonioscopic findings in the affected eye to those in the fellow eye may help the clinician identify areas of recession. More extensive angle recession is associated with a greater reduction in outflow facili and an increased risk of glaucoma. However, even with substantial angle recession, this risk is not high. Although the risk of developing glaucoma decreases appreciably after several years, it is still present even 25 years or more after injury. In a significant proportion, up to 50%, of fellow eyes, elevated IOP may occur, suggesting that some eyes with trauma that go on to develop glaucoma may have been predisposed to POAG. Alternatively, it is POACBLE. The fellow eyes were more likely to have sustained trauma as well. Because it is not POACBLE to predict which eyes will develop glaucoma, regular monitoring of all eyes with angle recession and their fellow eyes is recommended. The treatment of traumatic glaucoma is often initiated with aqueous suppressants, prostaglandin analogues, and A2 adrenergic agonists. Miotics may be useful, but paradoxical responses of increased IOP may occur. Laser trabeculoplasty has reduced efficacy in these patients. Incisional glaucoma surgery may be required to control the IOP in patients not responding to medical therapy.